Are you feeling nervous about approaching your OBGYN rotation as a med student? Or are you well versed in the signs and diagnostic methods for early pregnancy? Regardless of what level you're on or how confident you feel, let me share this exciting journey of discovering the wonder of new life. As a disclaimer, to all those using this resource as a study material for your boards or just personal knowledge, the information that's about to be presented to you is purely for entertainment purposes only. Most of the info you're about to be presented with is based on the current American College of Obstetrics and Gynecology guidelines and research as of this year. Please note that these guidelines are constantly evolving and changing, so always be wary of the information being presented to you. Leave a comment if you have noticed any changes from the time this video is posted or even if there are any errors in this video. Now, without further ado, the first set of signs of pregnancy we observe are the presumptive signs, which include amenorrhea, nausea and vomiting, breast enlargement and tenderness, linea nigra, which is the darkening of the midline skin of the abdomen, hyperpigmentation of the areola, abdominal bloating and constipation, increased weight gain, cravings or aversions to certain foods, increased urinary frequency, and fatigue. But to be sure of the pregnancy, we move on to the probable signs, which are physical findings that confirm pregnancy. These include Biddle sign, the cervical softening in the first 4 weeks. Hager sign is the softening of the lower segment of the uterus between 6 to 8 weeks. Latin sign is the softening of the midline of the uterus in the first 6 weeks. Chadwick sign is the bluish discoloration of the vagina and cervix between 6 to 8 weeks. Telangiectasias and palmar erythema are the small blood vessels and redness of the palms in the first 4 weeks. And finally, Closma sign, which is the hyperpigmentation of the face in the first 16 weeks. Once we have confirmed the pregnancy, we turn to the human chorionic gonadotropin levels to diagnose the pregnancy. The HCG is produced by the placental syncytiotrophoblasts and has a structure of alpha subunit, common to HCG, FSH, LH, and TSH, and a beta subunit, specific to the placenta. Its function is to maintain the corpus luteum during the first 8 to 10 weeks of pregnancy, and later shifts to the placenta to synthesize its own estriol and progesterone. To measure the HCG levels, we perform either a urine or a serum test. The urine test, also known as a home pregnancy test, is a qualitative test but less sensitive than the serum test. The serum test is quantitative and can detect the HCG levels 6 to 9 days after fertilization. The HCG levels normally double every 2.5 days for the first 4 weeks of pregnancy, peak at 8 to 10 weeks, and decrease during the second trimester before reaching a steady level during the third trimester. We also use ultrasound, either abdominal or transvaginal, to confirm the pregnancy and estimate the gestational age and expected date of delivery. The Nigel rule is used to calculate the due date but can be inaccurate with irregular menstruation cycles or conception while taking contraceptive pills. Ultrasonography is more accurate by measuring the crown rump length in the first trimester, by parietal diameter, fetal femoral length, and abdominal circumference in the second and third trimesters, and the symphysis fundal height to determine the growth of the fetus. Let me tell you, there's nothing more exciting than helping to bring a new life into the world. I'm excited to share the general principles and the step-by-step process of prenatal care that we provide to our patients. First and foremost, it's essential to understand the frequency of checkups during pregnancy. For our patients, until the 28th week, we see them every month. From the 28th week to the 36th week, we schedule appointments every 2 weeks. And from the 36th week until birth, we see them every week. However, in high-risk pregnancies, we may need to see our patients more frequently to ensure the safety of both the mother and the baby. Next, let's talk about preventive ethics. As healthcare providers, it's our responsibility to obtain informed consent from our patients during the prenatal period. This helps us manage ethical conflicts and ensure a safe environment for addressing any concerns and reservations our patients may have. We facilitate advanced discussions of procedures that may be necessary during the perinatal period, such as cesarean delivery and the management of fetal anomalies. This encourages informed decision-making and avoids any miscommunication or disagreement. The initial examination, which takes place around 10 weeks of gestation, is critical. We gather a detailed personal and family history, conduct a gynecological examination, and measure the patient's blood pressure and weight. We also perform standard laboratory tests, including a complete blood count, hemoglobin screening for anemia, TSH screening for thyroid disease, and blood typing, ABO and rhesus. Additionally, we screen for the risk of hemolytic disease of the newborn, urine dipstick protein testing for proteinuria, urine culture for asymptomatic bacteriuria, and screening for sexually transmitted infections such as HIV, syphilis, and hepatitis B and C. We also perform pap smear and ultrasound assessment to estimate gestational age. We provide our patients with general nutritional recommendations and vaccination advice. The seasonal influenza vaccine and the Tdap vaccine during the third trimester are recommended for pregnant individuals. We also perform third trimester screening for STIs for individuals who meet certain criteria, such as those under 25 years of age or those with new or multiple sexual partners. In subsequent examinations, we monitor the patient's weight and blood pressure, conduct a physical examination, and perform fetal heart monitoring through ultrasound or a cardiogram. We perform prenatal screening for Group B streptococcus between 36 and 37 weeks of gestation and repeat the HB test from the 24th week of pregnancy. The 50 grams, 1-hour oral glucose challenge test is performed at 24 to 28 weeks gestation, and a 100 grams, 3-hour oral glucose tolerance test is performed if necessary. Now, when it comes to screening, all pregnant women, regardless of age, should be offered non-invasive aneuploidy tests. This means that a simple blood test and ultrasound can be done to measure specific biomarkers and markers that indicate an increased risk of having a baby with an abnormal number of chromosomes. This can be done before 20 weeks of gestation. There are several tests available, including testing maternal serum, cell-free fetal DNA testing, and the quad or triple screen test. The most sensitive and specific screening test for common fetal aneuploidies is cell-free fetal DNA testing. This test can identify chromosomal aberrations and even determine the sex of the fetus from as early as 10 weeks of gestation. While non-invasive screening tests are a great option, all women should also be given the alternative option to undergo invasive genetic testing like amniocentesis or chorionic villus sampling. This is a more definitive way of determining the health of the fetus and its chromosomes. However, pre-test counseling must be provided to inform the parents that screening is voluntary and to explain the difference between screening and diagnostic tests, the risk of false positive and false negative tests, and the option of terminating the pregnancy if aneuploidy is diagnosed. When it comes to the first trimester combined screening test, the results of the nuptial translucency ultrasound, human chorionic gonadotropin, and pregnancy-associated protein in maternal serum are evaluated based on maternal age, lab results, and ultrasound. If the results are abnormal, further counseling and invasive genetic testing should be offered. The quad screen test and triple screen test, done between 15 to 22 weeks and 15 to 20 weeks of gestation respectively, measure the levels of HCG, alpha-fetoprotein, estriol, and inhibin in maternal serum. If the risk is elevated, counseling and invasive genetic testing should be offered. Invasive diagnostic tests like amniocentesis, chorionic villus sampling, and chordocentesis can be done to get a more definitive answer about the health of the fetus and its chromosomes. Amniocentesis can be done from the 15th week of gestation onwards and involves extracting amniotic fluid under sonographic guidance via transabdominal puncture. Chorionic villus sampling can be done as early as 10 to 13 weeks of gestation and involves removing chorionic tissue for genetic diagnosis. Chordocentesis is done after 17 weeks of gestation and involves extracting fetal blood for analysis. One of the ways we monitor the health and development of the fetus is through physical examination and ultrasound scans. During a physical examination, we use Leopold's maneuvers, which are 4 abdominal palpation techniques to determine the presentation, position, and engagement of the fetus in the uterus. First, we perform a bimanual examination of the fetal position, which could be longitudinal, oblique, or transverse, and the fundal height. Second, we perform a bimanual examination of the location of the fetal back, whether it's on the mother's left or right side. Third, we use one hand to grasp above the symphysis to determine if the presenting part of the fetus is engaged. If the fetus is in a cephalic presentation, the head will feel hard and balance-able. If the fetus is in a breech position, the soft and less movable rump can be felt. Fourth, we perform a bimanual examination of the location of the fetal brow and the degree of flexion of the head. This maneuver is usually performed during the later stages of pregnancy when the fetus has entered the pelvic inlet. During a pregnancy, we also perform ultrasound scans to monitor the health and development of the fetus. The first trimester ultrasound, performed around 6 to 8 weeks gestation, is typically done transvaginally. During this exam, we evaluate the presence and location of the pregnancy, determine the number of fetuses, confirm the gestational age, document the crown rump length and cardiac activity, and screen for abnormalities of the cervix, uterus, and placenta. The second or third trimester ultrasound, performed around 18 to 22 weeks gestation, is done transabdominally. During this exam, we evaluate the fetal presentation, number of fetuses, fetal anatomy and growth, estimate the amniotic fluid volume, and evaluate the placental position. In high-risk pregnancies or complications during pregnancy, we perform additional ultrasound exams, such as an ultrasound-guided first trimester genetic screening, ultrasound for cervical circlage placement, ultrasound-guided external cephalic version, and Doppler ultrasound. Doppler ultrasound measures the velocity of blood flow in the vessels and can indicate suspected fetal growth restriction, pregnancy-induced hypertension, suspicious cardiotocography, suspected fetal deformities or diseases, and assesses fetal anemia and hypoxia. Another type of test we perform in high-risk pregnancies is antepartum fetal surveillance to assess the risk of antenatal fetal death. The non-stress test is a non-invasive test that measures the fetal heart rate reactivity to fetal movements. A reactive non-stress test shows at least 2 fetal heart rate accelerations, and the patient is usually discharged with reassurance. A non-reactive non-stress test shows less than 2 fetal heart rate accelerations, and the patient is usually monitored more closely with additional tests such as a biophysical profile or contraction stress test. The biophysical profile is a non-invasive test that evaluates the risk of antenatal fetal death and measures parameters such as fetal movement, tone, amniotic fluid volume, and fetal breathing movements. Preventing mother-to-baby transmission of HIV is a crucial aspect of obstetrics. With proper knowledge and use of antiretroviral therapy and other medical interventions, the risk of transmission can be greatly reduced. However, the management of HIV in pregnancy involves a comprehensive approach, taking into account the mother's viral load, delivery method, and postpartum management. Additionally, hemolytic disease of the newborn, a potentially life-threatening condition caused by incompatibility of blood groups between the mother and fetus, is another important concern in obstetrics. Understanding the causes and pathophysiology of HDFN is essential in preventing and treating this condition. The fight against HIV transmission from mother to baby is a crucial and pressing issue in obstetrics, with the highest risk occurring during birth. But with the right knowledge and tools, we can minimize this risk and ensure a healthy outcome for both mother and baby. The transmission of the virus from mother to baby is a major concern, and it is highest during the birth process, also known as perinatal vertical transmission. However, it is possible for prenatal transmission to occur as well, and the risk is dependent on the mother's viral load. To combat this, we recommend combined antiretroviral therapy for the entire pregnancy and delivery period. The mode of delivery and the use of additional IV zidovudine must be considered to minimize the risk of transmission to the infant. Zidovudine is a crucial medication, as it is one of the few antiretroviral drugs approved for post-exposure prophylaxis in newborns. When it comes to intrapartum management, the maternal viral load near the time of delivery plays a key role in determining the appropriate delivery method and intrapartum antiretroviral treatment. For example, if the viral load is greater than 1,000 copies per ml or if the patient has poor adherence to ARV treatment, a cesarean delivery should be scheduled at 38 weeks and IV zidovudine should be administered 3 hours prior to the delivery. On the other hand, if the viral load is between 50 to 1,000 copies per ml, a vaginal delivery can be considered with IV zidovudine administration based on an individualized decision. If the viral load is less than 50 copies per ml, IV zidovudine is not recommended. It is also important to note that the intrapartum management of HIV also involves administering a 2-drug regimen consisting of zidovudine and nevirapine, or a 3-drug regimen consisting of zidovudine, lamivudine, and either nevirapine or raltegravir, depending on the maternal viral load. Additionally, zidovudine should be administered for 4 weeks postpartum. Postpartum management is equally important. We advise against breastfeeding in countries with good food availability and hygienic baby food, as the risk of transmission is 5 to 20%. In case of suspected HIV in infants, a diagnosis is confirmed via PCR, not ELISA, if the infant is under 18 months. Infants with failure to thrive, diffuse lymphadenopathy, diarrhea, and thrush, especially if the mother is a high-risk patient, should be suspected of having HIV. The regimen of zidovudine and nevirapine, or a 3-drug regimen consisting of zidovudine, lamivudine, and either nevirapine or raltegravir, can be administered based on the maternal viral load during the intrapartum period. As you can see, managing HIV in pregnancy requires a comprehensive approach and a deep understanding of the mother's viral load and intrapartum management. Hemolytic disease of the newborn is a condition in which there is an incompatibility of blood groups between the mother and fetus. This leads to the destruction of fetal erythrocytes by maternal antibodies, which can be a potentially life-threatening situation. There are several causes of HDFN, but the most common is a BO incompatibility, present in 20% of all pregnancies. Only 5 to 10% of newborns from these pregnancies are symptomatic. However, another cause of HDFN is Rh incompatibility, which is rare following routine anti-D prophylaxis. The Kell blood group system incompatibility is the second most common cause of severe HDFN, responsible for up to 10% of severe cases. Some risk factors for HDFN include maternal exposure to fetal blood during pregnancy, antenatal procedures such as amniocentesis, or cesarean delivery, pregnancy-related complications, and trauma. The pathophysiology of a BO incompatibility is highest when the mother has blood group O and the newborn has blood group O or B. Maternal antibodies against non-self antigens of the ABO system are present even if sensitization has not occurred, so fetal hemolysis may occur during the first pregnancy. In Rh incompatibility, the mother's exposure to fetal blood leads to the production of maternal IgM antibodies against the Rh antigen. Over time, these antibodies seroconvert to Rh-IgG, which can cross the placenta and cause rapid production of maternal IgG anti-D antibodies to fetal Rhd antigens. This leads to Rh-IgG agglutination of fetal RBCs, causing hemolytic anemia and increasing the risk of HDFN with possible hydrops fetalis. The KEL blood group system incompatibility is responsible for up to 10% of severe cases of HDFN. Maternal exposure to KEL antigen in a previous pregnancy or through blood transfusions leads to sensitization and production of maternal anti-KEL antibodies. These antibodies then enter the circulation of a KEL-positive fetus through the placenta, destroying fetal RBC precursors and mature RBCs, leading to decreased production of RBCs and increased hemolysis, causing severe fetal anemia. There is also a subtype of HDFN called non-immune hydrops fetalis, which is not caused by red cell alloimmunization. This subtype of HDFN is caused by congenital heart defects and arrhythmias, chromosomal aberrations, severe fetal anemia, and congenital torch infections. The pathophysiology of non-immune hydrops fetalis is due to severe fetal anemia causing hypoxia, which leads to decreased hepatic and renal blood flow, activation of RAAS, increased central venous pressure, and decreased lymphatic flow and fetal edema. Clinically, HDFN can present as prenatal hydrops fetalis in cases of Rh incompatibility and non-immune hydrops fetalis. Postnatally, newborns may present with neonatal anemia, hepatosplenomegaly, neonatal jaundice, hypoxia, prematurity, and scattered petechiae. A BO incompatibility usually has a significantly milder course of disease than Rh incompatibility, and anemia may conceal cyanosis. The diagnosis of HDFN requires evidence of hemolysis in the presence of fetamaternal blood incompatibility. Prenatally, ultrasound imaging can be used to determine hydrops fetalis and fetal anemia, and Doppler sonography can be used to assess blood flow and assess for anemia. Blood group typing of both the mother and the fetus can be done to determine if an incompatibility exists. Postnatally, a peripheral blood smear can be done to assess for hemolysis and anemia, and a bilirubin test can be performed to assess for jaundice. Additionally, a direct antiglobulin test can be performed to identify the presence of antibodies in the mother's blood that are causing the hemolysis. Treatment for HDFN depends on the severity of the disease and the presence of other complications. In mild cases, simple measures such as phototherapy for jaundice may be sufficient. In more severe cases, exchange transfusions may be necessary to remove the incompatibility and replenish the newborn's blood supply. In severe cases of prenatal HDFN, delivery may be necessary to prevent fetal distress and death. Prevention of HDFN can be achieved through Rh immunoglobulin prophylaxis given to Rh-negative mothers during pregnancy. This helps prevent the formation of Rh antibodies and reduces the risk of HDFN in subsequent pregnancies. Additionally, blood group typing of both partners during preconception counseling can also help prevent HDFN by identifying incompatibilities before pregnancy occurs. All in all, HDFN is a serious condition that can have significant consequences for both the mother and the fetus. Early detection and treatment is crucial in preventing severe disease and ensuring the best outcome for both mother and child. I want to tell you about the amazing physiological changes a woman's body goes through during pregnancy. It's truly a marvel of nature and a true testament to the strength and resilience of the female body. Starting with the cardiovascular system, we see a significant increase in cardiac output by up to 40%, which leads to an increased stroke volume and heart rate by about 12 to 18 BPM. This, in turn, leads to a better uterine perfusion. But the most fascinating part is the increase in progesterone levels, which leads to a decrease in vascular tone, resulting in a decrease in peripheral vascular resistance and a decrease in mean arterial pressure. You might even hear an innocent systolic murmur as a result of this increase in cardiac output and plasma volume. And as the uterus grows, it displaces the apex beat upward. The increased plasma volume also causes edema in the lower limbs due to decreased oncotic pressure. And let's not forget the varicosities and the potential aggravation of pre-existing valvular diseases. Moving on to the respiratory system, we see an increase in oxygen consumption by about 20%. As the uterus grows and causes an increase in intra-abdominal pressure, the diaphragm is displaced upwards, leading to a decrease in total lung capacity, residual volume, functional residual capacity, and expiratory reserve volume. But don't worry, the increased levels of progesterone stimulates the respiratory centers in the brain, causing hyperventilation to efficiently eliminate fetal CO2, leading to a physiological and chronic compensated respiratory alkalosis. The tidal volume and minute ventilation also increase, and we see a decrease in PCO2 by about 30 millimeters Hg. In the renal system, we see an increase in renal plasma flow and GFR, which leads to a decrease in BUN and creatinine levels. The increase in aldosterone levels causes a hypernatremia due to increased plasma volume. And as the uterus grows, it causes dilation of the kidney, pelvis, and callosal systems, leading to reduced tone and peristalsis. This could potentially lead to hydronephrosis and hydroureter, and urinary stasis caused by hypomotility of the ureters could lead to pyelonephritis. But on a positive note, there is an increase in urinary frequency. The increased glomerular filtration leads to an overload of the glucose carrier responsible for its reabsorption, resulting in increased glucose levels in the urine. And we also see mild proteinuria due to increased GFR and glomerular permeability to albumin. In the endocrine system, we see the progesterone hormone, responsible for pregnancy maintenance, being produced first by the corpus luteum and later by the fetal-placental unit. The human placental lactogen hormone, synthesized by syncytiotrophoblasts of the placenta, promotes the production of insulin-like growth factors and causes insulin resistance by increasing insulin levels and serum glucose levels. The maternal insulin resistance peaks in the third trimester. The HCG levels lead to a decrease in TSH levels during the first part of the first trimester, and the TBG levels lead to an increase in T4 and T3 levels. But during the second and third trimesters, the free T4 and T3 levels decrease. We also see an increase in SHBG and corticosteroid-binding globulin, and a rise in triglycerides and cholesterol levels due to increased lipolysis and fat utilization. The lactotroph cells in the anterior pituitary undergo hyperplasia, leading to a rise in prolactin secretion, which can cause lactation, galactorrhea, and decreased libido. These changes can cause infertility, osteoporosis, and decreased bone density. Women may experience menstrual irregularities and a decline in estrogen levels, leading to hot flashes, vaginal dryness, and increased risk of osteoporosis. Additionally, adrenal suppression can result in decreased cortisol levels, leading to adrenal insufficiency and decreased stress response. It's important to monitor patients undergoing high-dose glucocorticoid therapy and manage these adverse effects through dose adjustment, addition of bone protective agents, and hormone replacement therapy if necessary. The hematologic system also experiences changes during pregnancy. The woman's body experiences an increase in plasma volume, which leads to dilutional anemia, but also an increase in RBC mass, WBC count, and alkaline phosphatase. The woman's body also experiences hypercoagulability due to increased fibrinogen, factor 7, and factor 8, but a decrease in platelet count and protein S. The gastrointestinal system experiences changes as well, including increased salivation, decreased lower esophageal sphincter tone, and decreased motility, which can lead to constipation and bloating. The woman's body is also at risk of developing gallstones due to gallbladder stasis. The musculoskeletal system experiences changes due to increased body weight, forward shift in center of gravity, and increased lumbar lordosis. These changes can lead to diastasis recti, neuralgia paresthetica, pelvic girdle pain, and carpal tunnel syndrome. The nutritional needs of a woman during pregnancy must be adapted to meet the demands of both the mother and the growing fetus. It's recommended to limit caffeine intake to less than 200 milligrams per day, which is equivalent to about 1 to 2 cups of coffee or 2 to 4 cups of caffeinated tea. Alcohol and tobacco should be avoided throughout pregnancy. Raw, uncooked, or unwashed food should also be avoided to reduce the risk of foodborne illness. Fish with high levels of methylmercury such as tilefish, swordfish, shark, mackerel, and tuna should be limited, while other types of fish can be consumed in moderation. Milk products should be avoided due to the risk of congenital listeriosis, and meat should be avoided due to the risk of congenital toxoplasmosis. In terms of supplements, it's recommended for women to take folic acid starting 4 weeks prior to pregnancy and continuing for the first 2 to 3 months of pregnancy. This helps with fetal neural tube development and maternal and fetal erythropoiesis and reduces the risk of neural tube defects in the infant. Vitamin B12 is recommended for pregnant women who follow a vegan diet. Iron is recommended to prevent maternal anemia, while calcium is recommended for fetal bone development and lactation. Iodine is recommended to prevent maternal and fetal hypothyroidism. The recommended weight gain during pregnancy is determined by a woman's BMI prior to pregnancy. Women with a BMI less than 18.5 should aim to gain 28 to 40 pounds, while those with a BMI between 18.5 to 24.9 should aim for 25 to 35 pounds. Women with a BMI between 25 to 29.9 should aim for 15 to 25 pounds, and those with a BMI greater than or equal to 30 should aim for 11 to 20 pounds. Inadequate weight gain during pregnancy, defined as less than 0.5 pounds per week, may be due to loss of appetite, vomiting, eating disorders, malnutrition, or smoking, and can lead to higher risks of preterm birth, small size for gestational age, and decreased likelihood of postpartum weight retention. The average recommended daily calorie intake during pregnancy is 2,200 kcals in the first trimester and 2,500 kcals in the second and third trimesters. Regular physical activity is recommended during pregnancy. Physical activity during pregnancy is considered beneficial and is recommended before, during, and after pregnancy. However, careful evaluation of medical and obstetric disorders is necessary before starting a physical activity routine. Some of the common contraindications to aerobic exercise during pregnancy include severe anemia, restrictive lung disease, hemodynamically significant heart disease, cervical insufficiency, premature rupture of membranes, and gestational hypertension or preeclampsia. The following is a list of safe and unsafe activities during pregnancy. Safe activities include, but are not limited to, low-impact training like swimming, walking, stationary cycling, pilates, and yoga are all relatively acceptable and encouraged for patients to partake in during pregnancy. High-impact training such as running, jogging, racket sports, and strength training should be exercised with caution. No pun intended. Unsafe activities include contact sports, activities associated with a high risk of falling, activities associated with high risk of dehydration, and extreme sports. Physical activity should be discontinued if a woman experiences antepartum or postpartum hemorrhage, uterine contractions, amniotic fluid leakage, chest pain, dyspnea before exertion, dizziness, headaches, calf pain or swelling, or muscle weakness with impaired balance. High-risk pregnancy is a pregnancy that carries an increased risk of maternal and fetal complications. Early identification of high-risk pregnancies is important for preventative measures and regular prenatal care. Risk factors for a complicated pregnancy include family history of complicated pregnancies, personal history, advanced maternal age, first pregnancy, multiple pregnancies, medical conditions such as hypertension, diabetes, or epilepsy, social and environmental factors like drug use or stress, pre-existing gynecological conditions, prior complicated pregnancies, cesarean delivery, history of abortions or placental abruption, use of assisted reproductive technologies, and pregnancy complications that arise. Postterm pregnancy is defined as a pregnancy that progresses beyond 42 weeks since the first day of the last menstrual period or beyond 14 days of the estimated delivery date. The exact cause of postterm pregnancy is unknown, but risk factors include prior postterm pregnancies, advanced maternal age, prematurity, male fetus, obesity. Management of postterm pregnancy depends on patient preferences and gestational age, with induction of labor being the recommended option at 42 weeks or if oligohydramnios is present. Complications of postterm pregnancy include placental insufficiency, fetal dysmaturity, oligohydramnios, stillbirth, excessive fetal growth, and macrosomia. Multiple births are definitely a common occurrence in the hospital. The frequency of multiple births is calculated based on Helen's law, with twins occurring in approximately 1 out of 89 pregnancies, triplets in 1 out of 892, and quadruplets in 1 out of 893. The incidence of multiple pregnancies has increased since the 1980s due to the availability of assisted reproductive technology. Predisposing factors include advanced maternal age, previous multiple pregnancy, use of assisted reproductive technology, and a maternal family history of dizygotic twins. Twins can be classified as monozygotic or dizygotic. Monozygotic twins are genetically identical and occur when a fertilized oocyte divides into 2 embryonic layers, while dizygotic twins occur when 2 oocytes are fertilized by 2 mature spermatozoa. In monozygotic pregnancies, there are various ways in which the amniotic sac and placenta are shared. This can range from having separate chorionic and amniotic sacs to sharing both a single chorionic sac and a single amniotic sac. In very rare cases, the twins may even be conjoined. Diagnosis of multiple pregnancies typically includes a physical examination and ultrasound. A fundal height and abdominal girth that is larger than expected for the gestational age, as well as the presence of 2 or more fetal heart rates on auscultation, are signs of a multiple pregnancy. Ultrasound can differentiate between monochorionic and dichorionic twins, with the lambda sign indicating dichorionic twins and the T sign indicating monochorionic twins. Almost all complications associated with normal pregnancies are more likely in multiple pregnancies, including preterm labor and birth, hyperemesis gravidarum, gestational diabetes, preeclampsia, cervical incompetence, placental insufficiency, and increased risk of maternal morbidity. Additionally, fetal illnesses such as spontaneous reduction or vanishing twin syndrome and twin-to-twin transfusion syndrome can occur. It is crucial for both the mother and fetuses to be closely monitored during a multiple pregnancy, as early identification and management of complications can greatly impact outcomes. An ectopic pregnancy is a pregnancy in which the fertilized egg attaches in a location other than the uterine endometrium. There are several different types of ectopic pregnancies, including tubal pregnancy, which occurs within the fallopian tube, and interstitial pregnancy, which occurs within the interstitial portion of the fallopian tube. Ectopic pregnancies can either be complicated or uncomplicated. A complicated ectopic pregnancy is associated with severe bleeding, such as hemoperineum or vaginal bleeding, or a tubal rupture and requires surgical treatment. On the other hand, an uncomplicated ectopic pregnancy does not have any of these features and may resolve spontaneously in some cases. Heterotopic pregnancy is a rare condition in which a patient has both an intrauterine and an ectopic pregnancy. This occurs more frequently in patients undergoing infertility treatments, such as in vitro fertilization. In terms of etiology, the fallopian tube is the most common site of ectopic pregnancy, accounting for 95% of cases. Other sites include the ampulla, isthmus, fimbriae, ovary, abdomen, and cervix. Risk factors for ectopic pregnancy include anatomic alterations of the fallopian tubes, a history of pelvic inflammatory disease, previous ectopic pregnancy, surgeries involving the fallopian tubes, endometriosis, a ruptured appendix, exposure to diethylstilbestrol in utero, a bicornuate uterus, smoking, advanced maternal age, and various other factors such as intrauterine device use, hormone therapy, and in vitro fertilization. When it comes to the clinical features of ectopic pregnancy, patients usually present with symptoms around 4 to 6 weeks after their last menstrual period. These may include lower abdominal pain and guarding, vaginal bleeding, amenorrhea, nausea, breast tenderness, frequent urination, tenderness in the area of the ectopic pregnancy, cervical motion tenderness, and an enlarged uterus. If there is a tubal rupture, the patient may present with sudden and severe lower abdominal pain, signs of hemorrhagic shock, and possibly bradycardia. Interstitial pregnancies tend to present later, around 7 to 12 weeks of gestation, due to the myometrial distensibility. When a woman of childbearing age presents with general symptoms of ectopic pregnancy, or known risk factors, such as fallopian tube alteration, we consider ectopic pregnancy as a potential diagnosis. If the patient is hemodynamically unstable, we take immediate measures to stabilize her. If trained, we may perform a point-of-care ultrasound to identify intraperitoneal free fluid or confirm an intrauterine pregnancy. If IUP is confirmed, we evaluate for other causes of instability, but if there's free fluid or findings suggestive of ectopic pregnancy, we refer for surgical exploration without delay. If POCUS is performed, the results can supplement clinical suspicion for surgical exploration. In stable patients, we send a serum beta-HCG test and arrange or perform a pelvic ultrasound, regardless of beta-HCG levels. If ectopic pregnancy is visible on imaging, we begin treatment. If IUP is visible, we consider alternative diagnoses. If ultrasound results are indeterminate, we arrange follow-up and repeat imaging. We test all women with abdominal pain for pregnancy, regardless of contraceptive use. Up to 20% of ectopic pregnancy cases can be hemodynamically unstable and require immediate therapy, so we don't delay stabilization and treatment to confirm the diagnosis. In terms of laboratory studies, a single beta-HCG level can increase verifiably from the 8th day after ovulation, and the BHCG discriminatory level, typically beta-HCG greater than 1,500 to 2,000 μU per ml, is the point at which an IUP is usually visible on ultrasound. An inability to visualize pregnancy above this level may suggest ectopic pregnancy. Serial beta-HCG measurements taken every 48 hours are more accurate in differentiating IUP from ectopic pregnancy. The expected increase in beta-HCG for normal IUPs varies based on the initial level. Less than 1,500 μU per ml should increase by greater than 49%, 1,500 to 3,000 μU per ml by greater than 40%, and more than 3,000 μU per ml by greater than 33%. Falling beta-HCG levels may indicate a failed IUP or ectopic pregnancy, with a drop of greater than 21% suggesting a failed IUP and a drop of lesser than 21% suggesting ectopic pregnancy. Insufficient decline in serial beta-HCG levels following induced abortion should raise suspicion for ectopic pregnancy. We also conduct CBC tests to check for anemia, blood type and screen tests, liver and renal function tests, and imaging tests such as transvaginal ultrasound. TVUS is the best initial test for determining pregnancy location, and empty uterine cavities, possible free fluid, extravariant adnexal masses, tubal ring signs, interstitial line signs, and thin myometrial layers can all provide supportive or additional findings. This can be a difficult and challenging experience for a woman. But with the right treatment approach and support, we can ensure the best outcome for her health and future fertility. First, it's important to determine whether a patient is stable or unstable. Unstable patients need immediate stabilization and an OB/GYN consult for emergency surgery. For stable patients, we evaluate the clinical, laboratory, and radiological findings to determine the appropriate treatment plan. This could be medical, surgical, or expectant management. It's important to involve the patient in the decision-making process and provide adequate supportive care for all patients, regardless of the management approach. Patients who are suited for medical or expectant management at home will receive education on red flag symptoms indicating a ruptured ectopic pregnancy and arrange for appropriate follow-up prior to discharge. Supportive care, including pain management and prenatal and contraceptive counseling, should be provided to all patients. It's also important to remember to administer anti-D immunoglobulin to all Rh-negative patients who present with bleeding. Medical therapy using methotrexate is the treatment of choice for uncomplicated ectopic pregnancies in hemodynamically stable patients with an unruptured mass, a beta-HCG level of lesser than or equal to 2,000 to 5,000 mlu per ml, and a mass size of less than 3.5 centimeters without a fetal heartbeat. However, there are absolute contraindications to using methotrexate, including chronic conditions such as severe asthma, creatinine clearance less than 50 milliliters per min per 1.73 m2, and alcohol use disorder or chronic liver disease, as well as breastfeeding, immunodeficiency, and peptic ulcer disease. There are 3 different methotrexate regimens for medical treatment of ectopic pregnancy: a single-dose regimen, 2-dose regimen, and multiple-dose regimen. The multiple-dose regimen has a higher success rate but also more adverse effects compared to other regimens. The administration of methotrexate and folinic acid is done on specific days, and beta-HCG levels are monitored to evaluate the effectiveness of the treatment. If beta-HCG levels increase or plateau during weekly follow-up, it could indicate a persistent ectopic pregnancy. For patients who have contraindications for methotrexate or have had unsuccessful medical treatment, non-urgent surgical management is recommended. The preferred approach is laparoscopy with a procedure called salpingostomy, which is the removal of the ectopic pregnancy without removing the affected fallopian tube. However, there is still a risk of persistent or repeat ectopic pregnancy, and serial HCG measurement and prophylactic dose of MTX may be necessary. Unfortunately, this condition is often fatal for the fetus and can cause great distress for the mother. While the maternal mortality rate in the U.S. is relatively low at about 0.6 per 100,000, the emotional toll on the family can be significant. One question that often comes up from med students is about the future fertility of patients who have experienced an ectopic pregnancy. The answer depends on the patient's fertility status prior to the ectopic pregnancy, but in general, it can be a difficult road ahead for those who want to conceive again. Another concern for patients is the risk of recurrence, which occurs in about 10% of cases. It's important for med students to be aware of risk factors, such as a history of spontaneous miscarriage or tubal damage, and to take these into account when treating patients. In addition, women over the age of 30 are also at a higher risk for ectopic pregnancy. As a physician, it's important to be mindful of these factors and provide supportive care and guidance to patients throughout the process. Ectopic pregnancy can be a difficult and emotional journey, but with proper care and attention, we can help women navigate this challenging time. Now let's talk about the medications that expectant mothers can and cannot take during pregnancy. First, let's talk about penicillin. This group includes ampicillin, amoxicillin, flucloxacillin, penicillin V, and piperacillin. They're safe and effective for pregnant women. Next, we have cephalosporins, which are also considered safe. And last but not least, macrolides such as erythromycin and azithromycin are also safe options. However, there are some antibiotics to avoid, including tetracycline, which can inhibit bone growth and lead to malformations and yellow discoloration of the primary teeth. Aminoglycosides, such as gentamicin, can lead to hearing loss and CNA toxicity. Trimethoprim, sulfonamide combinations increase the risk of cardiovascular birth defects and neonatal jaundice. Chloramphenicol can cause gray baby syndrome, leading to ashen gray skin, cardiovascular collapse, and abdominal distension. Clarithromycin is embryotoxic, while fluoroquinolones can cause damage to bones and cartilage. Antihypertensives also require special consideration during pregnancy. Methyldopa and beta blockers, particularly metoprolol and labetalol, are safe to use in the first and second trimesters. However, they should be avoided in the third trimester. Dihydrolazine and nifedipine are also suitable options. But diuretics and ACE inhibitors, as well as angiotensin receptor blockers, can lead to significant harm, including reduced placental perfusion, oligohydramnios, fetal renal hypoplasia, poor cranial ossification, fetal death, and severe renal malformations. Atenolol can cause intrauterine growth retardation and decrease placental growth. Antifungals also have specific recommendations during pregnancy, with topical imidazoles and nystatin being safe options. Systemic amphotericin B is also suitable. However, antifungals such as ketoconazole, Flucitosine and grisofulvin, as well as itraconazole and fluconazole in high doses, are to be avoided due to teratogenic and embryotoxic effects. Iodides can lead to congenital goiter. When it comes to antivirals, acyclovir and valacyclovir for herpes and oral oseltamivir and zanamivir for influenza are safe options. Zidovudine plus lamivudine plus nevirapine plus atazanavir is a suitable combination for HIV infection. However, efavirenz can lead to fetal neural tube defects. Ribavirin can cause preterm birth and significant teratogenic and embryocidal effects, while interferon and the combination of ribavirin and interferon can lead to lactic acidosis and hepatic failure, potentially resulting in death. Nevirapine can cause potentially fatal hepatotoxicity and should not be used as first-line therapy if avoidable. Finally, anticoagulants also require special consideration during pregnancy. Heparin is the anticoagulant of choice and does not cross the placental barrier. Low doses of aspirin may be prescribed for high-risk preeclampsia, but high doses should be avoided in pregnancy due to the risk of bleeding and potential harm to the fetus. Warfarin is not recommended during pregnancy due to the risk of birth defects. Women who are pregnant or planning to become pregnant should discuss the best options for anticoagulation with their doctor. Regular monitoring and dose adjustments may also be necessary during pregnancy to ensure the safety of both the mother and the baby. Now, let's talk about the most controversial topic in pregnancy today: abortion. Induced abortion is defined as the use of medical interventions, such as medications or procedures, to end a pregnancy. Within this category, there are two subtypes of induced abortion: medication abortion and surgical abortion. Medication abortion involves the administration of medications, while surgical abortion involves the physical removal of the products of conception from the uterus. In terms of epidemiology, data from the United States in 2017 indicates that approximately 18% of all pregnancies ended in abortion, with 60% of these procedures performed within the first 10 weeks of gestation. The common indications for induced abortion include a patient's choice to end the pregnancy, anticipated harm to the individual, and genetic or anatomical abnormalities in the fetus. Prior to an induced abortion, several steps need to be taken, such as confirming the pregnancy with a urine pregnancy test, assessing the gestational age using ultrasound or the patient's last menstrual period, and considering an ultrasound if necessary for patients with symptoms or risk factors for ectopic pregnancy, a history of irregular menstrual cycles, or a last menstrual period greater than 56 days prior or unknown. In preparation for the procedure, it is crucial to confirm the pregnancy through a urine pregnancy test, determine the gestational age through assessment or ultrasound as indicated, and engage in shared decision-making with the patient to select the method of induced abortion. Patient education is a critical component of the preparatory process and includes informing the patient of the expected symptoms and adverse effects of induced abortion. These can include but are not limited to heavier bleeding and cramping compared to menstruation, gastrointestinal symptoms such as nausea, vomiting, and diarrhea, and low-grade fever and chills. Additional care may also be indicated, such as referral for psychosocial services, contraception counseling, and STI screening. It's crucial for our patients to feel comfortable and have a positive experience. One of the procedures we perform is induced abortion, and it's important for us to consider the methods of induced abortion and all its details. Medical abortion is one of the methods of induced abortion, and it's performed during the first trimester of pregnancy, which is defined as 12 weeks gestation or less. In the early stage of the first trimester, up to 10 weeks gestation, a combination of mifepristone, an oral progesterone antagonist, and a prostaglandin analog such as misoprostol, administered 24 to 48 hours apart, is used. Alternatively, the misoprostol single-agent regimen can also be used. However, the combination of methotrexate and misoprostol is no longer recommended as standard of care in the U.S. After 10 weeks gestation, the procedure is managed the same as a second trimester abortion. The second trimester of pregnancy, between 13 and 24 weeks gestation, is referred to as a labor induction abortion. The preferred method is mifepristone followed 24 to 48 hours later by a prostaglandin analog, such as misoprostol. However, misoprostol monotherapy or oxytocin, which is rarely used, can also be used as alternatives. In this stage, the procedure is performed using dilation and evacuation. Medical abortion has several advantages, including being non-invasive, not requiring anesthesia, and may be performed at home during the first trimester. It is also preferred for certain medical conditions and results in less perceived bleeding than medical abortion. The confirmed removal of products of conception is also an advantage. On the other hand, medical abortion usually requires follow-up and takes longer to complete than the abortion procedure. It is contraindicated in patients with current IUD or ectopic pregnancy. Dilation and curettage is another method of induced abortion, and it is invasive, requiring anesthesia, and always performed in a clinical setting. After an induced abortion, it's important to confirm the abortion or evaluate for any complications. This is done by obtaining a serum HCG level and performing a pelvic US to evaluate for a gestational sac. If a gestational sac is present, expectant management or repeat-induced abortion should be considered. Patients should be counseled on recommended follow-up, which includes a pregnancy test 4 weeks after the abortion and seeking medical attention for symptoms of incomplete abortion or complications, such as prolonged or excessive pain or bleeding. A routine follow-up visit is not required for uncomplicated induced abortion, but one should be offered to all patients. The management options for an incomplete abortion after an induced abortion include watchful waiting, medication abortion, or procedural abortion. It is imperative that we learn about the consequences and the importance of medically supervised abortion. Medically supervised abortions have a very low rate of complications. Some of the most common ones include hemorrhage, infection, disseminated intravascular coagulation, cervical laceration, uterine perforation, retained products of conception, and even pulmonary embolism or amniotic fluid embolism. However, this list is not exhaustive and there may be other rare complications that can occur. In the event of a complication, the management should be prompt and thorough. Hemorrhage should be treated with appropriate hemodynamic support and sepsis management. If there is evidence of trauma, the patient should undergo a fast exam and an urgent surgical consult should be initiated, if necessary. A pelvic examination should be performed to assess for products of conception, injuries, and signs of infection. A CBC with differential, type and screen, comprehensive metabolic panel, and HCG should be obtained. Cultures of blood, cervical, and endometrial aspirate should also be taken. Imaging studies such as an ultrasound pelvis or CT abdomen. Pelvis may be performed to evaluate for complications such as internal bleeding, incomplete abortion, retained products of conception, ectopic pregnancy, pelvic abscess, bowel injury, or hematoma. On the other hand, unsupervised self-managed abortion is a dangerous practice. In 2017, 18% of non-hospital facilities in the U.S. treated women following self-management. Initial management of these patients should involve stabilizing any life-threatening complications, performing a pelvic examination to assess for products of conception, injuries, and signs of infection, and obtaining diagnostic studies if necessary. It is important to identify and treat any potential complications such as organ dysfunction, uterine perforation or bleeding, abdominal or pelvic organ injury, or infection. If no complications are present, the patient should be provided with expectant management and a pregnancy test should be performed 4 weeks after the abortion. I must also note that as of June 2022, medical practitioners are not required to report individuals who have performed an unsupervised self-managed abortion. This is a crucial aspect to consider as abortion is no longer federally protected under the Constitution of the United States. Providers should be aware of local laws and regulations when counseling patients on their options and ensuring that the procedures are performed in accordance with state and federal laws. In conclusion, pregnancy is a true marvel of nature, showcasing the strength and resilience of the female body. The physiological changes a woman experiences are truly awe-inspiring, from the cardiovascular system to the respiratory system, to the renal system and beyond. But as we delve deeper into this wonder of life, it raises questions about the mysteries of the human body and the intricacies of nature. How does the body adapt to these changes so seamlessly? What other secrets does the female body hold? And how can we continue to unlock and understand the mysteries of pregnancy and the human body as a whole? As we marvel at the beauty of new life and the incredible transformation a woman undergoes during pregnancy, let us also ask ourselves, what other wonders of the human body are waiting to be discovered? Stay tuned to find out all of the pregnancy-related disorders that will be covered on part 2 of this topic. Happy studying! If you found this video useful, share it with other average med students such as yourself. If you want to get in contact with me directly, reach me on my Instagram DM. My handle is provided in the description below.